Okay, so the topic is hyperthyroidism. Hyperthyroidism or thyrotoxicosis is constellation of clinical features that arise when thyroid hormone is increased. When T3 T4 concentration in our body is increased, that condition is known as hyperthyroidism. There are multiple causes of hyperthyroidism like Graves' disease, T-quinine thyroiditis, pain-less thyroiditis, TSH secreting adenoma, and infectious thyrotoxicosis, and like amiodarone drug toxicity or any ovarian dermoid tumors or teratomas. So these can trigger thyroid hormone and hyperthyroidism occurs. This is a condition. Now clinical features of hyperthyroidism, general features will be weight loss, increased appetite with heat intolerance and fatigue, while skin will show sweaty, pruritus, palmar erythema. Heart will show systolic hypertension, tachycardia, and anxiety, irritability, hyperreflexia, tremor. Reproductive system will show oligomenorrhea, infertility, impotence, hyperdefecation, diarrhea, grittiness, diplopia, lid leg, and um, and exophthalmos. So we will look at the most common disease of hyperthyroidism. That's Graves' disease is an autoimmune disease associated with thyroiditis and hyperthyroidism, and it epidemiology occurs in 30 to 50 years of the patient. Female predominance, family history can give rise to this condition. And those patients who have HLA-B8 and HLA-DR3 positive, smoking patient can develop Graves' disease. Pathogenesis of Graves' disease is it is type 2 hypersensitivity reaction, IgG antibody mediated reaction. Immunoglobulins act on the thyroid follicle and causing thyroid receptor antibody trap can be detected, and hyperthyroidism occurs. Clinical feature, there will be goiter which will be diffuse, non-tender, and thyroid bruit will be there. Exophthalmos, lid leg, and proptosis can be seen in the patient. T cell infiltrates will be retroorbital in space, edema, accumulation of glycosamine glycans, increased number of adipocytes, and fatty infiltrates can be there. So diagnosis on the basis of tests like for diffuse thyroid, we will look at for the ophthalmopathy and dermopathy. We will look at the T3 T4 level, TSH level will decrease, bilateral diffuse uptake of the antibodies, trap will be positive, and in this way we can diagnose the thyroid hyperthyroidism. So treatment will be beta blocker for palpitation and tachycardia control. Antithyroid drugs should be given like carbimazole, methimazole, propylthiouracil, and complications of the propylthiouracil can be hypersensitivity, agranulocytosis. Methimazole can give rise to the arthralgia and fever, while propylthiouracil can cause hepatocellular necrosis. In pregnancy, antithyroid drugs should be given as a treatment of choice for thyrotoxicosis in pregnancy. First trimester, there should be propylthiouracil should be given because methimazole is teratogenic. In second trimester, methimazole should be given. So in this way, we can give other treatments are the radioactive iodine should be given. These are absolute contraindicated in pregnancy, and uh, radioactive iodine can cause hypothyroidism or worsening ophthalmopathy. So in this way, we can treat the patient of hyperthyroidism.